Welcome, welcome. I am Dr. David Geier, orthopedic surgeon and sports medicine expert. Welcoming you. I can't even talk. It is Tuesday night and I've had a really long day, but excited to be here. I am here for Ask Dr. Geier Live. I'm going to take, 10 minutes, 20 minutes, 30 minutes and answer any sports and exercise injury questions that you may have. I've been doing YouTube now for about 4 years, but just started doing the live videos recently. But I've been answering medical questions, injury questions, things like that for years and years, I think since 2010. And so it's one of the things I really like to do. I don't get to answer I get about 200 a week on YouTube, and I can't nearly answer all of those. So I try to do these occasionally to answer as many as I can. A few things before we get started is that, thank you so much. I don't know, that's 113. I am not the best, but I really appreciate that. Thank you for joining us. Two things to kind of keep in mind. One, as I say this in my videos, I say this in my podcast, I say it on my website. This is not meant for specific medical advice because I'm not your doctor and haven't seen you and examined you and looked at x-rays or MRIs. So what I'm going to answer is meant for general information and educational purposes. It's meant to help you. It's meant to help you decide, do I go see a doctor? What should I ask? That type of thing. But it is not telling you specifically what to do. The other thing is, please keep the questions short. It makes it easier for me to read, quite honestly, trying to get the questions in these little chat bubbles. And honestly, everybody else just wants the synopsis of what the question is, not a long, drawn-out answer. Leslie, I appreciate it. Thank you. I'm glad that you learned something new from the live feeds. So actually, before I start answering questions, I'm glad, very cool, third year medical school. I remember those days like they were yesterday, even though they were a fair ways away. Med school is really, really rough, especially some parts of third year. I was just talking about my cardiothoracic surgery rotation, third year medical school earlier today. So I remember it well. Good luck with third year, but it's all great. A couple things, or one thing I do want to mention, and I'll start answering questions. I've mentioned this on my podcast. So if you've ever listened to my podcast on iTunes, I do a weekly podcast and I talk about, a big health topic. Then I talk about, I wasn't big on pathophys either. I talk about a topic that affects pro athletes, college athletes, youth sports athletes, and then I answer some questions. I am thinking long and hard about making that a live podcast where I do a live video stream on YouTube. So I would still do some topics, but then people can leave comments on what I'm talking about. And then toward the end of the show, we would transition to Ask Dr. Geier questions, do 3 or 4 of those. So if that is something that you're interested in seeing in 2019, a live podcast, a live video stream every week that's not just answering questions, but it's also topical right now or later on, after this is over, leave some comments below and let me know what you think. Is that Sanj? My screen is really small today. So like I was saying, more live videos. If I do more, it's going to be in the format of the Dr. David Geier Show podcast, but live because I answer questions there. But that's weekly, so you'd get more of an opportunity. All right, there's a few questions we'll start out with. Again, remember, keep them short, and it's not specific medical advice, but there's a few that I said that I would answer through this, people that left me questions yesterday or today. So first one, Fontenoy 58. I recently had surgery for a broken clavicle with plates and screws. The middle section of my clavicle was displaced. Now they're aligned with plates. How long does it take to heal the bone and take it out of the sling? Will it be strong as before? So yes, if it heals, it would heal completely. Plates and screws. It's interesting about clavicle fractures. When I was training, we rarely fixed them. You put them in a sling and said, they're going to do fine. We realized over the years, though, that a lot of people were still weak. A lot of them didn't have great motion, and they didn't heal real well. If the gap is really significant, that's really tough to get those to heal. There's just so much space. So you at least want some sort of contact between the ends of the bone. If there's a big gap, that doesn't typically do so well. So we fix a lot more of these than we used to. And if you line them back up, hold it with a plate and screws, that should go on to heal. Now, that can still take 8 to 12 weeks until that's solid, but that should go on and heal. How long the sling, that's really a surgeon preference. I usually get people out of the sling pretty quickly because, again, the plate's holding it in place. So, but by getting them out of the sling, they work on getting their motion back and things like that. All right, let me pull up some of these. Sanjay, getting surgery, ACL surgery, November 28th. Super excited. Your videos have helped. I am really thrilled. I hope it goes great. Hopefully you can get in a little bit of time to build some quad strength before surgery. I think that's really helpful, but I wish you good luck. Keep us informed on your progress over the coming months after your surgery. All right, let's see here. Try to get back through some of these. Where are we here? All right, Jimmy Roberto Flores, and I maybe the name's cutting off on my screen, says something about, will a partial torn ACL heal by itself? Should I have my MRI the very next day after the ACL injury or not? When you have the MRI, typically has very little to do with the quality of it. That's not one that, like a big swollen knee, makes the MRI any less effective. So I think do it the day of, the day after, do it 2 weeks later, 2 months after. It'll still show a torn ACL or not a torn ACL. The thing about a partial ACL tear, and I'll tell you, Jimmy, check out, I've got a couple videos on my YouTube channel about this. So a partial ACL tear is a radiology diagnosis, meaning that what they're seeing is some of the fibers still intact, some of them not. It's not a clinical diagnosis. What matters with an ACL tear is whether the ACL is stable and whether or not the knee is stable or not. So it's somewhat based on, is it 90% torn or 20% torn. That's part of it, but it's a question of whether or not the fibers that are still there are actually stabilizing the knee, whether they're doing what they're supposed to be doing. The vast majority of the time in ACL injuries with these high-grade partial ACL tears, there's very little of the ACL still attached, and what's left is all stretched out. You can tell for sure, and this would be something that your orthopedic surgeon could tell, is if there's a bone bruise consistent with a torn ACL. Hold on, let me find my knee model. Hold that thought. So if for the ACL, if it's torn, your tibia is going to shift forward and rotate, and there's going to be an impact on the lateral side of the knee. And if you see that bone bruise pattern, I don't care how much of the partial ACL is intact, that knee is unstable. There's no way for you to have that bone bruise pattern with a partial ACL tear, with an intact ACL. So I think that's one that I would have the surgeon examine your knee, review the MRI, look for things like that. But in my experience, and I'm sure I've done over 1,000 ACL surgeries, the vast majority of partial ACL tears are that high-grade partial ACL tear where the knee is still unstable. So hopefully that helps. Madison Snotterly, if your shoulder seems loose when lifting or throwing, what are some of the probable diagnoses? No, that's a good question. So, I mean, we're going to think, before you think of any injury, you think of somebody that, excuse me, getting over a cold, you think of somebody that's naturally ligaminously loose. And so you may only notice it on the one side if you're right-handed, for instance, and you're throwing with your right side, overhand, or you're doing it underhand for softball or something. So it could be that you're naturally ligaminously loose, and you can kind of tell that if you can bend your thumb back and touch your forearm, or if your elbows hyperextend or your knees hyperextend, things like that. But once you get out of that, it's possible to have shoulder subluxations where the ball isn't necessarily coming completely out, but it's partially coming out. And there's a variety of injuries, traumatic things that can lead to that. But I suppose you could develop that just over time. In theory, I guess maybe you think labral tear, where that's the cartilage bumper along the socket, that somehow somebody had a labral tear and then it's riding over that cartilage bumper, causing discomfort, things like that. So good question. Let's see. I've missed some of these here. Leslie Montemayor, I may have said that wrong. I apologize, Leslie. I had to have my kneecaps realigned after years of my kneecaps dislocating. My left kneecap is popping out again. Could physical therapy be helpful, or will I need more surgery? Terrific question. I literally just had a guy in my office Monday, I think, that had that surgery on one side, didn't have it on the other side, and his surgical side was doing a lot better, but he was starting to develop a little bit of arthritis. He was like 20 years out from the surgery. I think that generally, I think physical therapy is worth trying. Patients can always go back and do surgery down the road if they're not getting anywhere with it, but I think that without knowing more, it's possible that maybe the quads have gotten weak and that's allowed the kneecap to kind of slide around a little bit more or something like that. I think it's worth a shot for most patients to try a course of physical therapy, but it depends on what happened with that dislocation. Did the graft tear? What exactly happened? So I wouldn't tell you it's impossible for somebody to need surgery. Hopefully not, though. That would certainly be good generally. All right, Jada Lynn, after building quad strength for almost a year, I'm finally strong enough for my MPFL surgery this Thursday. Good luck with that. How long should I take off from school before going back? That's a great question. And I get, I don't know, a third of my patients, maybe a little bit more than that, are high school students. So this comes up a lot. Let's do the school thing first. We'll do the surgery. So the surgery is very much like the kneecap dislocation. Typically, it's a reconstruction of... All right, if you're looking at the knee head on, that's the patella. This is the outside of the knee, the LCL. The patella tends to dislocate laterally, so you reconstruct this band of tissue that you don't see on this model with usually a hamstring graft or something like that to rebuild what's called the medial patellofemoral ligament. Typically, I usually have people take certainly the day of surgery off, obviously, because you're in surgery, the day after off because they're groggy with anesthesia, and then kind of decide from there. If it's a Thursday, that means then you're Friday off, Saturday, you got the weekend. I think it's conceivable somebody could be back on Monday for sure. But, obviously see how you feel and go from there. All right, another question that I promised to answer. Let me do that. V. Lone. I had meniscus surgery a few months ago. They just took out the torn part. I was playing football on a Friday, took a weird step, can't walk on my left knee, can't straighten it, wondering if it could be a new tear. Well, it's certainly possible to re-tear a meniscus. I think it's not as likely to have a second injury if it's trimming out the meniscus as compared to sewing it back together. So I think that going to see the doctor, icing it, maybe go to physical therapy. Even, yes, getting an MRI to see is an option, but it's possible. I can't give you percentages. I don't think it's terribly likely, but, if it's not getting better pretty quickly, it's worth checking out. All right, a couple of questions that have come up since I did that one. I've been dealing, this is Suze John. I've been dealing with osteoarthritis in my right knee. Was wondering if the swelling on that same side in the foot as well. I may have misunderstood this question, but typically my experience with knee swelling from any cause, osteoarthritis or anything else, meniscus, ACL tear, typically stays in the knee. It doesn't usually shoot down the leg. I suppose it could, but I haven't seen that all that often. So maybe worth talking to your doctor. Now, sometimes what you see is because a body part hurts, in this case, maybe the knee, you walk awkwardly, you put more stress where it's not normally. So if it's one knee, then maybe it's that foot and ankle, or it's that hip, or it's the other knee. And then you start to get issues along those lines. So that could be along the lines of what you're talking about. And I didn't see the first question, Suze. I'll try to go back and look at it somewhere. It must be way up earlier in my timeline. Tobias, I broke my tibia and fibula. How long should it take to heal, and what should I do? This is going to be a different answer for kids than for adults, but in adults, tibia fractures almost always need surgery. Usually a rod down the center of the bone, sometimes a plate and screws. The fibula may or may not need surgery based on where along the, is it toward the bottom of the bone, toward the ankle, or the mid shaft? Because those, that typically will tell you if that needs surgery. Reza Hyder, what does most orthopedic surgery differ on the same opinion? One doctor pushes more towards surgery, another asked me to leave it as it is. Elbow fracture. So, you're with a lot of injuries, be it elbow fractures or anything else, there's not a lot of these, there's not an absolute this needs surgery or absolute it doesn't. I mean, there are some that do. A lot of fractures do, but sometimes that's not the case. It depends on the bone, depends on how well it lines up, how active the person is. So I think that those sometimes are reasons that you might get different opinions from different people. I'm fairly conservative by nature, so I try to err on the side of no surgery. But in the sports medicine world, where people are trying to get back to a very, very high level of activity, sometimes then they are more likely to have surgery. And Robert, I really appreciate that. Thanks so much. But that's the reason you're not always going to get the same perspective. And then you talk to maybe a trauma surgeon versus sports medicine, you're going to get very, very different answers. So that is kind of where that comes from. Sandy Kamara, I had rotator cuff surgery 5 weeks ago, still in the sling, going to physical therapy. All of a sudden, have more stiffness with movement. Ice or heat better at this point? All right, so first of all, I'm going to say that talk to your physical therapist because they're going to have a very interesting opinion on the ice versus heat typically. I'm not a huge fan of heat for after surgeries. I think it makes the joint swell, and I think that it can increase inflammation. Now, if you used it just to warm up the shoulder, maybe before you started doing exercises to loosen up, maybe that's okay. But generally, in terms of something you do several times a day, I think ice is more important. Getting motion back after rotator cuff surgery is really, really tricky. And so I think working hard with a physical therapist, working hard on it on your own is really important because it doesn't happen often, but a small percentage of people do develop essentially a frozen shoulder after rotator cuff surgery. So it's something that you really have to work on. Let me do another one from up here. Sue's followed up. Basically, getting swelling in my foot spreading down from the knee that has osteoarthritis. Would that warrant another follow-up? I gotcha. Maybe, I think it's worth asking, is there anything going in my foot? Is there, could this just be coming from the osteoarthritis? I'm not saying that somebody's knee swelling couldn't go down into the foot. It's a closed joint, so that's not a joint that tends to, as most, the elbow, the shoulder, they don't tend to spread down, but gravity, I suppose, especially if there's leg swelling, I suppose could do that. All right, another one that I said I'd answer, and this one I may have to do on my podcast or in a video at my channel, the Ask Dr. Geier videos. Justin asks, what tendon do you think is the strongest for ACL surgery for an allograft? So I talk a lot about on my channel graft options for autografts, meaning you use tissue in your knee to make a new ACL. So the patella tendon, the hamstring tendons, and those typically autografts are fairly equal. There's some caveats to that, but generally I think they're both good. And I think autografts typically are stronger than allografts. So as I've said on my videos many times, I really prefer autografts. Yes, it's more uncomfortable for the patient early, but I think it has better long-term success rates, much lower re-tear rates. Among the allografts, though, I don't know that I know all the data or that there's because there's so many variables, but the surgery can be successful with any of them. I've used the patella tendon allografts with the bone plug on either side. I think that can work well. I've used the soft tissue allografts where you do the all-inside ACLs, and those can do well. I think generally the bigger question, what is the surgeon comfortable doing? Autograft versus allograft, though, I think is the bigger question I think most patients for ACL surgery have to answer. Leslie, you're welcome. I'm very, very grateful that's helpful. Godfrey Lockwood, hope you're doing okay. Quick question. When you have a broken femur, yikes, should you suffer joint knee pain? It's been 9 months since I broke it. Yeah, this gets back to, I forget who asked the question earlier, but where sometimes you do have issues where, you go on and it's one body part, but while that's healing, more stress is going to another body part. So I have absolutely seen knee pain. I don't do tons of femur fractures. That's more the trauma orthopedic surgery world. But back when I used to take level 1 trauma call at an academic medical center, we'd do femur fractures. And sometimes you'd get some knee pain. It can be related to the rod if they fixed it with a rod down the bone, or it could be just stress from maybe your strength hasn't come back completely on one side. But that is not uncommon. All right, Donna from the UK. 6 years ago, I dislocated my right ankle. during climbing, fractured my tibia. Recent activity stops me doing 5K walks. Compartment pressure, I didn't see the end of that. Real bad. I'm not sure necessarily the question, but that can be a difficult problem. If you developed a compartment syndrome after a tibia fracture, that is really difficult. It's not to say you can't overcome that, but that ends up usually needing another surgery. Let's see. I think I've answered most of these. Muhammad, do you advise leg press or rather knee extension to build up quadricep strength after meniscus tear surgery? Well, after meniscus surgery, it's not as important how you do the strengthening as compared to an ACL surgery. After an ACL surgery, you would not want to do resisted leg extensions for about 6 weeks. Some people say more, like 12 weeks after ACL surgery. Meniscus surgery, the only limitation would be if they sewed the meniscus back together, there may be some motion restrictions and weight-bearing restrictions. But if it's the trimming out type, I think any of that is good. The nice thing about squats and leg presses is you're doing both legs at the same time, and your foot is either fixed to the floor or to another surface, so it makes it's what we call a closed chain exercise. Makes your quads and hamstrings fire simultaneously, which typically is safer for the knee. Tobias, I really appreciate that. I'm glad you find this helpful and happy to be here. All right, I'm going to stick around for a few more minutes. So send your last questions. Reza says, what's the difference between a trauma orthopedic surgeon and a regular orthopedic surgeon? Okay, so there's lots of subspecialties of orthopedics. After I did my orthopedic training, which is 5 years, then you can go on and do one more year of a subspecialty. So I did a year of orthopedic sports medicine surgery. There's sports medicine, there's trauma that I talked about. So you do orthopedic surgery, then some training in trauma. There's joint replacement, there's foot and ankle, there's shoulder and elbow, there's tumor, there's hand, there's spine, and pediatrics. I think that's all of them. And so orthopedics has really gotten to be very subspecialized. Now, general orthopedic surgeons just do their 5 years training and do a little bit of everything. They're not specialists on any one thing. So depending on what the injury is, a lot of times people will want a specialist in that field. A lot of times it may depend on where you live and what you have access to, but those are the thoughts. So obviously I'm sort of biased towards subspecialist and in my case sports medicine, but it's not to say that you couldn't do well with those, with a generalist. Muhammad, you're very welcome. I'm glad it was helpful. Godfrey, would you recommend I get a steroid injection for the knee pain? I think, again, that's probably a better question for your doctor. It really depends on what's going on. Is it wear and tear of the cartilage or something like that, or is there a structural injury? I'm not an enormous cortisone fan guy. I'm not a cortisone shot fan or a cortisone shot. I think that it's fine for, fairly advanced arthritis and things like that. I don't typically do it, and I don't know you at all, but if you're young or something like that, I typically try not to avoid it and try to see what the underlying issue is on the front end. I'm going to stop there. Those were awesome questions. You guys are the best. I love doing this. Again, if you got time later on, give me some thoughts on the live podcast, what's the name of my podcast? The Dr. David Geier Show, potentially adding a live stream on YouTube, and we would do that show live probably Wednesday nights starting in 2019. I got to figure out the tech stuff, and if you're interested, I would do it. If there's not a lot of people interested, I probably wouldn't. Thank you so much for being here. Look forward to doing this whenever I can. Check out my videos that I put up now 4 days a week. Make sure to subscribe, and I look forward to seeing you very, very soon. You guys take care. Leslie, you have a great night too.